Hello, everybody. Reed here. Today, we're going to have another interesting discussion on hepatitis C. You know, the liver is responsible for metabolizing all of the substances, all of the medications, and things like that, right? But if the patient has a viral infection that impacts the liver, then what happens there? Um, you know, does that viral infection like hepatitis C have any impact on the way the medication is going to be metabolized, in the liver? I think these factors have to be taken into consideration, and that's what we're going to do here um, today. So let me see here. Okay, I was going to go to, let's see, chat, chat TDV. Okay. All right. So explain viral hepatitis and the risk when providing. Um, okay, let's go ahead and look at this. Today we had a patient with hepatitis C, right? And didn't really know the contribution that the hepatitis C was actually making to the whole presentation. And then if the patient does present with some bizarre symptoms and you see they have an infection like HIV or hepatitis C, it's important to sort of start looking to see, what's causing these, if these medical problems are causing the psychiatric conditions, right? So when we talk about hepatitis C and things like that, we're talking about the possibility that organ system dysfunction can actually result in psychiatric symptoms like psychosis, like delirium, like depressions and things like that, right? Okay, so now we want to see if you have somebody with hepatitis C, what medication should you avoid, right? Okay, viral hepatitis refers to inflammation in the liver caused by infection with hepatotropic viruses, primarily hepatitis A, B, C, D, and E, right? Um, and I'm more concerned about hepatitis C virus, okay? Each type has different transmission routes, patterns of illnesses, and implications for medication use. Okay, hepatitis A, fecal oral, right? Okay, no chronic. Hepatitis B, blood and sexual contact. Acute or chronic, yep, 5 to 10% of adults, chronic infection. Hepatitis C, blood needles, and things like that, often asymptomatic, 7 to 80%. So hepatitis C. Okay, hepatitis D requires hepatitis B co-infection. Okay, hepatitis E, fecal oral. Okay, pathophysiology. All forms of viral hepatitis cause hepatocellular injury, that is damage to the cells, inflammation, right? Okay, inflammation, and then remember, the necrosis here is the death, and necrosis creates a lot of fibrous tissue and things like that. So you get inflammation of the tissue, you have death of the tissue, of the cells, disruptive metabolism. This is what we're looking at here. It infects drugs, toxins, and bilirubins. So if you're having some, now this liver is responsible for a lot of things, particularly metabolism, things like that. So if you get hepatitis, you gotta have a good idea what you're gonna do next. This leads to elevated liver enzymes, AST and ALT, and impaired detoxification and metabolism. So impaired detox, that is drugs, detox here, metabolism. Yeah, okay, right. Medications risk to viral hepatitis because the liver metabolizes most drugs. Any hepatic inflammatory or damage increase the risk of drug accumulation, toxicity, or worsened injury. Right. So, okay, right. Because the liver metabolizes most drugs, any hepatic inflammation or damage increases the risk of drug accumulation, drug toxicity, and worsening injury, right? So it's very important to know which ones you can and you can't. Okay, altered drug viral hepatitis results in altered drug metabolisms. The Hepatitis decreases cytochrome P14 450 enzyme activity. Let me get the music in the background. Okay, here, see, altered drug metabolism. Hepatitis decreases cytochrome P450 enzyme activity, impairing drug clearance, right? And so we have to be careful because we may have to start the dose at a lower dose than we would normally start it at. Next, drugs with the highest first pass metabolism, such as opioids, beta blockers, and benzodiazepines, may accumulate. Right. So remember, the drugs that undergo first pass metabolism when you take them orally, the ones that heavily undergo first pass metabolism, particularly the opiates, beta blockers, and benzodiazepines, may accumulate because it doesn't go under the first pass metabolism, so it's not degraded as fast. Okay, the prodrug requiring hepatic activation may become less effective. So if your medication is in the inactive form, then it needs to be metabolized first to release the active form. Then that process may be slowed down in the face of viral hepatitis due to its altered drug metabolism. So we have it slowing down the P415 activity, first pass metabolisms, and prodrugs may not be activated as fast. Next, risk of hepatotoxicity. Patients with viral hepatitis are more susceptible to liver injury, right, from acetaminophen, NSAIDs, statins, anti-epileptics, antifungals, and certain antibiotics may exacerbate hepatocellular death. Next, 3, drug interactions with antiviral therapy. Drug interactions with antiviral therapy, such as hepatitis B, hepatitis Z, antivirals, can interact with drugs. Immunosuppressant or chemotherapy may worsen viral replication or liver toxicity. Next, impaired protein bonding. Reduce albumin synthesis, right? Increase the free drug levels of protein-bound drugs like warfarin or phenytoin. Yeah, so viral hepatitis reduce protein bounding, so reduce albumin synthesis, and so you get the reduced production of albumin. Yep, cumulative stress, hepatic stress, concurrent alcohol use, herbal supplements, or multiple hepatically cleared drugs can overload the remaining healthy hepatocyte. Look, herbal supplements, right? Medication guidelines in medication prescribing guidelines in viral hepatitis. Assess baseline liver function such as AST, ALT, AST, LP, bilirubin, albumin, INR. Great. Avoid or reduce hepatic drugs. Yep. Use renal clearance alternative as possible. Yeah, so use the ones where you bypass the liver and that needs to be excreted by the kidney. Something like lithium, like an example of that. Lithium, since it's an ion, it doesn't need to be metabolized, so it doesn't really need the liver. So it just needs to be excreted by the kidney in order to get out of the system. Adjust doses frequently, especially for drugs with narrow therapeutic indices. So we want to use lower dose and try not to lose the long acting. Right, the long acting medications may worsen the situation. Monitor closely, regular LFTs for long-term therapy, and educate the patient. So avoid alcohol, herbal detox products, or self-medications. Clinical example, a patient with chronic hepatitis C develops pain. Avoid acetaminophen. Prefer low-dose opiates. Regularly monitor the liver. And I think, let me see, viral hepatitis. Let me see, what are the risk of it says, what are the risks of prescribing psychotropic medications such as antipsychotics, mood stabilizers, etc.? Let me just see here to try to see what it says about, prescribing, because I want to hit on things like Depakote, since Depakote can cause hepatotoxicity and things like that. I just want to hit on some of those. Okay, excellent question, a very important one. When treating patients with viral hepatitis, prescribing psychotropic medications such as antipsychotics, antidepressants, mood stabilizers, anxiolytics, etc., carry specific risks, but most of these drugs are hepatically metabolized. See? Yeah, except lithium, most of the psychotropic medications are hepatically stabilized. But so if you have hepatitis or whatever, you want to make sure you sort of have a good idea of what you're prescribing, and can exacerbate liver injury or accumulate to toxic levels if hepatic function is impaired. Let's break it down clearly. Overview: why psychotropics are risky in hepatitis. Reduce hepatic metabolism. Yep. Okay, great. So why are psychotropic risky in hepatitis? Remember, we had the discussion further up here. Got to avoid here. Same thing, like avoid liver, reduce drugs, decrease the frequency, lower the half-life. Right. Same here. Okay, why psychotropics are risky in hepatitis? Reduce hepatic metabolism. Yep. Direct hepatotoxicity. Okay, drug-drug interactions and altered protein binding. So why psychotropics are risky in hepatitis? Reduce hepatic metabolisms. Drugs or their metabolites accumulate, right? Increasing sedation, EPS, and or toxicity. So because there's inflammation in the liver, the entire metabolic structure doesn't work as well, so you don't get the breakdown of these substances, and so you get an accumulation of the substances, and the accumulation increases sedation and EPS and toxicity. Right? Great. Now next is why psychotropics are risky in hepatitis. Direct hepatotoxicity. Some psychotropic medications can cause idiosyncratic or dose-dependent liver damage, such as Depakote, remember? Valproex, right? So be careful there. Drug-drugs interaction, especially with antivirals, such as antivirals with hepatitis B and hepatitis C, right? So drugs intravirus actions, because they can be on antivirals drugs. Altered protein binding. Low albumin levels in liver disease increase free drug low albumin level in liver disease increase free drug concentration. Wow. So if you have hepatitis or the liver is damaged, then the liver is likely going to produce less albumin. Because the liver is producing less albumin, then that means that they're going to be more free concentration of the drug flying around, circulating in the bloodstream active, because there's not enough albumin to bind all of it up, right? Because the liver is not producing enough albumin. So the ultra protein binding secondary to low albumin level is one of the reasons why you can get side effects because of elevated drug concentrations. Hope that makes sense. Okay, major psychotropic classes and hepatic risk. Antipsychotics, look, the old one, chlorpromazine, thorazine. So these are typical. Okay, I thought these were high potency. I thought these, okay, we're the same thing. Okay, CYP2D6. Yep. High risk can cause cholestatic hepatitis, okay? Haloperidol and flufenazine, which is prolixin, high potency. CYP3/4A, moderately. Use cautiously and monitor EFTs, okay? Clozapine and olanzapine, CYP1A2 and CYP3/4A, moderate to high. May cause transaminitis or rare hepatitis, monitor closely. Risperidone and quetiapine. CYP2D6, CYP3/4A, moderate. Dose reduction may be needed in hepatic impairment. Yeah, that makes sense. Okay, aripiprazole, ziprasidone, losiridone, through CYP3/4A, lower hepatic risk and generally safer, but still monitor It's generally safer, but still monitor LFTs. Okay, paliperidone, minimal hepatic metabolism, safest choice in hepatitis. Okay, sounds good. Okay, great. For the mood stabilizers, look at just the class of mood stabilizers. Depakote has hepatic risk. Depakote very high, can cause hepatotoxicity in especially in pre-existing hepatitis or children. It's contraindicated, and yep, it's contraindicated. Yeah, it can cause hepatotoxicity, especially in pre-existing hepatitis or children. It's contraindicated in active liver disease. Next, carbamazepine. Risk of idiosyncratic hepatitis, monitor ALT/AST closely. Lamotrigine, yeah, generally safe but rare hepatotoxicity. Yeah, Lamictal, I don't see Lamictal causing hepatitis many. It can cause Stevens-Johnson syndrome, so look that one up. Lithium is renally cleared, right? It's the safest option in hepatitis because it's a ion, so it doesn't need to be metabolized. It just needs to be excreted. And then topiramate, which is Topamax, and gabapentin, which is Neurontin, minimum hepatic metabolism. It's a safe alternative for mood disorders, for mood and anxiety disorders. Okay, antidepressants, right? We have SSRI, SNRI, tricyclic antidepressants, MAOs, metabolites, and bupropion. All of these categories basically safe, relatively safe, mild enzyme, heavy CYP. Yeah, these are heavy CYP metabolites. Avoid and serial, Paxil and Prozac here, they have very long half-lives. It's very, very long half-lives. So you want to avoid these because they have long half-lives. Okay, SNRI, duloxetine is contraindicated in chronic liver disease, venlafaxine with chronic. Tricyclic antidepressant, the risk of hepatotoxicity, so we want to avoid if possible, right? MAOs can cause hepatic necrosis, so avoid. Mirtazapine, if possible. Bupropion, rare. So here, I guess for antidepressants, the recommendations would be simply an SSRI, Zoloft, Celexa, or Lexapro. They're safe, mild enzyme, but I think just these three for the SSRI. So I would think everything else comes with some degree of risk. Okay, benzodiazepines, lorazepam, oxazepam, temazepam. Okay, the safest metabolized by glucuronidation. Okay. So for the benzodiazepines and hepatitis, glucuronidation is preserved in the liver. So the medications that are metabolized through glucuronidation won't be impacted by the hepatitis. Of course, you don't go into the glucuronidation is a difference in the CYP system. Diazepam, clorphazepam, clanapine, avoid long half-life accumulating the hepatic impairment. Okay, look. I think that's all we need right now. Okay. Yeah, so I think that's it now. So here, this hopefully that's be helpful for you guys in discussion of hepatitis, things like that. Let me see if I have it. I think I have one. My Max, my man. Max come through with my question all the time. Thanks, bro. How does hepatitis C impact metabolism, psychotropic medications? Yeah. You're safest with just SSRIs and things like that, but each one of them have their different properties. And so we sort of review those and stuff. So I think it's sort of clear from now. I think that's all I have for today, guys. I'm going to try and keep these lectures to 20 minutes, things like this. So I'm going for too long. And so next discussion I'm going to have, I think, is coming up after this one. I'm going to go through alcoholic hepatitis and cirrhosis of the liver. So stay tuned next for alcoholic hepatitis and cirrhosis of the liver. And feel free to like, subscribe, and share. Dr. Reed, take care of yourself. Ciao, guys.